Hi there, this is Steve Buchanan. I think this is our 6th or 7th live demo. This one is really interesting. We're going to do a treatment on a C-shaped molar, lower second molar, tooth number 31. It's been severely inflamed for a couple months. These can be some of the hardest teeth we treat because of the challenges of the irregular canal anatomy and that there is more fin than there is primary canal. Go ahead. Next image. Here's a CT view of the same tooth. You can start to see the curvatures. We have a cervical curvature in the mesial. We have apical curvatures in all the canals. Go ahead. This is, click through these. We're going to look at the cross-sectional views. The axial views show us the C-shaped molar. Okay, and this is the orifice level. Continue on. You can see there's a mesiolingual root kind of separating out from the distal and the buccal, which are hooked together. This is pretty classic C-shaped molar anatomy. I expect to find an ML canal that is actually its own primary canal, its own exit. Anything we find from the mesial buccal to the distal will almost certainly join with the distal and exit. Go ahead. Next image, please. Keep going. There you go. There's the last one. And let's see, there are a couple of other measurement images there. Okay, go back one. This is a view I was able to capture through the mesial, I think this is the mesiolingual and the part of the buccal. The curvature appears to be in a severe buccal direction. That would explain why it kind of gets fuzzy on the radiograph and hard to see. Next image. Here are the lengths as determined by CT scan. Dimensions are accurate in CT land. That's a really wonderful part about it. The mesial is 21.79, so we're going to call it 21 for the mesiolingual canal. The distal canal is about 23 millimeters. Next image. Okay. Is this the one you're going to crop? Crop this, we can't see diddly. Cool. Can you zoom that? Okay, you can't see anything on this image, but it's measured to where the curvatures start. And the two lengths there were what? I gave you. Yes. The short lengths are we don't want to go any further than 18 millimeters in the mesiolingual because that's where we're going to encounter the severe curvature. The distal is 20 to the severe curvatures. So that's I have my pretty close to my total length, and I have a safety length. Okay. We're using a 250 millimeter lens here. Do you have the bite block? Let's go ahead and do that. This is my favorite rubber dam frame. It's got a hinge to it. Open real wide. Bite down on that just a little bit. Great. And let's get the cotton. Oh, was that right here? Yeah. Is that it? Is that where you want it? Yes. Or is it on it? Okay. Okay. And this tooth is restored with ceramic. Anesthesia in this case was, actually I gave her everything. I gave her a Galgate's block with a carpule, 2 carpules of lidocaine, 1 to 50,000 epinephrine. Gave her a half carpule of articaine in the buccal, but this buccal shelf is so thick, I'm concerned about having the accessory innovation taken care of, so I also put an X-tip behind. If you look here, this little thing poking out here, that's the X-tip. So if we lose anesthesia, I'm just going to put a syringe needle right through there. We're going to have instant anesthesia immediately. That's very cool. It just perfuses the whole medullary space, so wherever the nerve comes from, it's going to be anesthetized. That's a trick taught to me by my good friend Ryan Facer. Turn to the right for me. Awesome, awesome endodontist in Salt Lake area. Okay, we're going to start the access. Remembering that buccal canals are working cusps, we're going to cut close to the working cusp. This might be too tight of a lens, but we'll see how it goes. Okay, I like the initial. I don't want to go past the midline if I can help it. There. That is a lot of porcelain. Or is that a composite material? Ceramics? Okay. You think it's composite? Actually, it cuts like a composite crown. Really good looking. Okay, I'm going to use my long taper diamond burr. Actually, this is the XL. I don't have room for a second molar. I'm going to just use the surgical length. As I often said, that one of the most important things you check initially is the length to the pulp chamber floor, which is about where the clamp is. So if I mark that, let's go ahead and do that just so everybody knows what that looks like. A little Sharpie mark, you can do it on the radiograph, you can measure on the CT, is going to give you an accurate reading. But you need to know where the no-fly zone is. That sounds like a simple, overly simple thing to do, but what it does is it takes out 33% of your challenge in access. Your access challenge is you're trying to do an XYZ. Now with this, let me get my microscope view better. Good. Got a good view here. Okay, here we go. Now we're seeing more orthogonal to the tooth. I know I'm not going to go deeper than that. So, also I want to make sure I have the angle of the tooth. So I put the burr in the embrasure space. And I'm in. The only reason I care so much about positioning the access is because I don't really need to think about it after I have my guided access burr. But I want to make my initial entry within the envelope of my final perfect, or as good as I can get it. There I am. I've dropped in the pulp chamber. We see there's some pulp tissue just under there. Cool. All right. This tooth reproduces your symptoms to hot, cold, percussion, biting pressure. Really no radiographic signs at all. Referred pain, really pretty classic. C-shaped molars can be really tough because they have a really an additional blood supply over most second molars. Again, getting this angle. And so they will take longer for the pulp to degenerate, which means they can come in way more inflamed than you're used to dealing with. Okay, so the first move with an LA diamond burr is Just moving circumferentially to find the pulp chamber limits. This is different, it's C-shaped molar, so we're going to take an extra careful look here. Always checking to make sure the little pilot tip is still on the drill. It is. How are we doing here? Okay. Yeah, looks like I expected. So I'm going to open up the lingual side. Let's move this back just a little bit open.
Can you check the
Great.
tip one more time?
Hmm?
Can you check the tip?
Oh, it just left. Doing okay?
Mm-hmm.
Great. Okay, my assistant was watching out for me. She was concerned that we didn't have enough of the pilot tip left on the end to be a truly guided burr. At this angle. This is the only axis that's going to be a little bit different shape. It's actually kind of C-shaped since that's the internal anatomy. All right. Nice. I think we got the mesiolingual line angle just in the right place. Look at that pulp. Yeah, that thing is like half gone. Teeth that react to heat typically have partial necrosis. I'm going to just tune this up with an ultrasonic tip. This is a buck 1 from Spartan Obtura. Let me see if I like my smaller mirror better. So cool having both mirrors on the same handle. I'm going to unroof some of this pulp chamber. I'd like to keep the access as conservative as possible, as long as I'm not going to miss anything in terms of treating all the anatomy. Also, I want to take off these pulp horns because they will inhibit the movement of fluids. Watch, please. And then we've got this irregular line here. This is going to reveal, I think, the buccal isthmus. So in C-shaped molars, most of them, they're all a little bit different. Most of them have, most of them have a independent mesiolingual canal, and they have a separate buccal distal complex together. Okay, Katie, could you process that, please? Thank you. Okay, we need to have 2 of those. There we go. Almost looks like a pulp stone in there. Oh, nice. Everything comes off of one opening right here. So we need to unroof a little bit over there. Okay, let's see if I can use this new Traverse orifice enlarger. This is part of the new RCT line of design for them. Could you turn to the right for me? Thank you so much. We have an awesome patient here. Sorry. Lower molars are tough to get good microscope angles on. Good. Do we have another mirror? This thing is shot. Okay, these are Zerk mirrors. I love them because they throw 30% more light back. Ah, nice view. Okay, so here's my little orifice widener. This is a 2508. It's got really cool heat treatment on it. So that's too fast. I usually use these about 600 RPM. They're short, they fit into molar accesses before you've got your glide paths all created. Here we are in the mesolingual. Turn this way a little bit, great. Bear with me on the angles. Mesolingual line angle. Here's the distal. And I'm going to walk that around to the buccal. Okay, suction. Okay, wow. Check this out. Here's Straight Explorer. Obviously, the distal is really straightforward. It's huge. The mesials, I'm not getting any tug back here. I can't get tug back. When Explorer, it usually means I'm not going to be able to get into the orifice with a file. Let's wash this again. Here's my DG16B. Check it out. There's the mesolingual. It has a gnarly curve. We saw in the pre-op films an amazing curvature. So having the bend in this end is really good for mesial canals. And the distal, if you're doing minimally invasive endo, having the distal one bent like this, you can sneak under dentin ledges and get a really nice outcome. Let's kind of tune things up with the LA access burr. So our requirement for gentle wave is 2.5 millimeters. We look and see that we have 3.5 that way. We have 5 the other way. So we're good. We don't need any more length at this time or any more opening. I'm just going to open get the distal a little, turn to the right for me. Thank you. Distal buccal just needs a little tune up. Off, please. I'll bring my syringe in next time, so it's really tough. I've got you on a bad. Okay, that is nice. I'm going to open the mesial just a taste. This may not have, oh, nice, there we go. All right, we're starting to see the C-shaped orifice here. It starts from over here. Let's open this up for you guys. I'm going to put the Buck 2 in here and just sand this little pulp chamber floor. Sometimes helps define whether, it certainly will tell you whether you have an attached denticle, which I don't believe we have here. This too is really hardy. You can operate it at full power on your ultrasonic tips or power unit. Great, okay. And distal lingual is that extent, and then it comes around. There's the orifice over to the mesial lingual. Let's zoom in a little bit. I've got to open that orifice around the buccal so we can be assured that the multiple frequency sound is going to be able to get in all these places. So here we are in the distal, smoothing that orifice level. Remember, it's sound, it wants to concentrate in a tapering shape. So it's kind of cool, the natural shape of root canals, which is tapered. Totally lends itself to this. I'm using Zeiss Pro Magnus microscope. It's a Zeiss. It's the old predecessor to the Pro Ergo, and it's a little bit more spare. Same functionality. It's got the little magnetic locks, which I really love, especially for live demos. Okay. I've got this on a lower RPM. Really don't want to spend any extra time undercutting these both horns. But if those aren't cut out, then they can interfere with the exhaust of the gentle wave and lessen our negative pressure inside. Do not want that. Forgot to mention, this one, as most C-shaped molars, is exactly right on the IA canal. So we got to make sure we're biocompatible. Okay. I'm going to tune up the mesiolingual line angle. Watch, please. I don't think we're ready for that yet. I've got a True Vision 3D heads-up camera on top of it instead of oculars. On the side, I've got an Optronics 2D camera for the image you're seeing. 3D is more important for the operator than for like lectures. I use it because I don't want to have a neck and a backache every time I do a procedure. Instead, I sit back in my chair, I look up. It's the most relaxed method of practice I've ever experienced. Let's see if we can get a file in there. I'm going to put the Explorer, the Bennett Explorer. There we go, the DG16B. Mesolingual. Okay, we've removed a big part of that curvature. Let's see if this little guy is going to get into that. Nice thing about orifice wideners is they've got a little bit of heft to them, so you can use them, and they're short. Let's see if this will go around. You know what, I need a longer file. 1506. Okay, so access is interleaved with negotiation. We're going to see that right now. I'm going to go ahead and do a little bit of early enlargement on the mesolingual canal because that's going to help me.
Can you
Back
hand
just a
the
little bit
wire,
right
please?
there. That's all we need. Can you grab that cotton pellet, cotton roll? Great. There we are. That's too high in RPM. I've got 500 RPM here. I'd rather have 300. I'll take a new one of those. I repeat this in all my lectures. What's our mesial safety length?
18.
18 millimeters. We're not going deeper than 18 millimeters in this thing. Before we have cleaning and all the pulp out of the way, etc. Okay. Taking out frequently. We don't want to shove debris laterally. That's really antithetical to our mission, which is get all the junk out. Nice. Let's see what it feels like in the distal. The distal safety length was what, 21?
20.
20, okay. Yeah, we've got more than enough. Can I have a 25 broach?
Right.
Let's see if we can get some of that tissue out of the distal. Okay, so the trick to using broaches, because you never know which size you want, is I usually just use a 25, but if you bend it, it will conform to the perimeter of any shape of canal. And that's all we want, is for it to sweep around the perimeter, engaging the pulp in the little broach barbs. And I actually keep turning it as I'm pulling it out. In this case, the thing is probably mostly degenerated, so there's not much. Oh, there we go. Got a little piece. Okay, the apical segment. Let's see what it looks like. Nice. Okay, I still need to open up that the buccal isthmus.
I was born there.
Did you feel that in your tooth? Okay. Do we need more anesthesia? Are you okay now?
Oh.
Great. Okay. Can you put the little mini section in there? Okay, let's open those little isthmi. So the white you see on the right side there, that's not pulp chamber floor. We usually have a darker color. It's not the typical dark gray that we see in many of these. Usually removing the white gets you into the canals, but you're never going to use that as a rule because I've been outside of a route before trying to accomplish that. Usually I find lower molars more difficult because up and down are a little changed, but left and right still the same mini section. Thank you. A little bit this way, thank you. Doing the root canal is easier than getting the right angle. Let's see if I can. Okay, we're going to give you more anesthesia. This is why we have. What's going on? This tooth has been severely inflamed. I was surprised we didn't have more problems with it beforehand. Let's see if we can. Stop came off. Would you tell me if your tooth is sore when I tap on it? Okay. Okay, here's the needle supplied by the X-tip people. There's that little opening. Just be exactly in it or it doesn't go in. There we go. No. Yeah. That little stop is giving me fits. I'm just going to put it through the side where there's not a big hole, if I can. You have another stop? Okay. Can you feel that? Good. We're using Sit-Nest Forte. We have to use limited epinephrine. You okay? Does it feel different now? Were you having, okay. Turn to the left section. You okay there? Okay, she's numb. Yay. Always way better. Okay, so back in the case, turn the right for me. Thank you. EDTA. EDTA is an awesome aid to access. Often we can't find things, calcified canals and such, because there's a smeared layer covering it. Yeah. You don't have to ask me. If I can't see anything, okay. Let's get this little guy opened up. Move on. I'm kind of looking forward to platforming it and seeing what GentleWave does. As I said before, this is probably one of the best tests of multi-sonic cleaning. I'm just going to start it with this so I get a little bit wider rounded edge, and then we're going to continue this with a smaller 1A. So far, there's no mesial buccal or buccal canal that's shown up. Usually we have a ML, and then we have, as I said, independent. Okay, we need a smaller tip. Also going to see if the orifice widener can help us out here. Now when you put a 1A on, it's half the tip diameter. So instead of 1 for the 1 millimeter, it's a ½ millimeter. I don't have, oh yeah, never mind. You must turn the power down or you'll blow them apart. The longer the tip is, the less power it takes to resonate the tip. And if you overdrive them, they're gone. So I'm going to put this at about 65. These are also a little bit longer. Because of the CTs, I can see there's connection all along here. It may be further down inside the root. Okay, much more control cutting. Again, this is not because I'm going to get in there and do a bunch of instrumentation. I'm probably not doing any instrumentation. This is so that I can know that I'm going to have no impediments to the GentleWave. Let's go 70. Just about done with this. You can see it's opening up a little isthmus right there. Let's just take a look, man. The more of a student of anatomy you are, the more fascinated you'll be, and also the better you'll be at doing root canals. Let's just cut this back away. Question? What's the question? EDTA, a weak acid removes the smeared layer. It doesn't matter what you use. There's a concept that was put out by marketing people that you can over etch a canal. That takes like 4 hours or something. It's not complicated. It's really straightforward. The biggest problem we have is you can buy it over the counter for almost nothing. So that is a little hard to build a product line on. Okay. And then the mesial lingual. I'm still learning how to use this thing, and it's not totally balanced out. Okay. I don't think there is necessarily a buccal canal in this thing. I think this 1A is about done. I don't think it will, but let's see if the orifice widener will get into that buccal isthmus. Okay. Again, it's easier to do the root canal and get a good video image. Here we go. This is the mesolingual. You can move the microscope if you think we could get a better view. We're good now. Okay, so in the distal, I'm gonna move it, see if it'll come to the buccal. You know, it really doesn't want to do that. I don't think there's much there. Okay, let's see if we can get to lengthen these canals. I'm sorry, I just want to put the LA diamond in there and touch this once, the mesolingual. It really does make things easier if you just, if you take each of the orifices and open them up a little bit, come in at the angle. This is at 1/4 normal RPM. There we go. Exactly what I want to see. No egregious enlargement, a really smooth, continuous drop in there. Let's see if I can create the same thing in the distal. If you're not using electric high speed, you should be. Electric high speeds are awesome. You could say take the same burr and run it at 3 different RPMs and have it act like 3 different burrs. Okay, distal. We are just about there. EDTA, please. So my line angle in the mesolingual is good. I've got a smooth contour in the distal. Instrumentation should be pretty straightforward. Let's see if we have any, if we can find that buccal. Get the other one. Get the stainless steel one. Thanks. So, stay there. Take a close look. Doing okay, Andrea? Mm-hmm. All right. You're being super still. Thank you. I'm seeing an isthmus for sure. Let's see if my bend explorer gets in there. I got tug back. That's pretty cool. I'm planning on filling these with a carrier because I think carriers are probably the most 3D technique we have. Wash. That's looking really cool. I wish these were just a little shorter. Lower teeth are harder to deal with than yours. Since I learned how to do intermittent switching with Yoshi, I'm just going to break this off. It's too... maybe this is the only time I'll need to have a sharp tip device. No, the one is already done its job. It's pretty big. I want something a little actually pointy. Usually pointy things in endo are horrible because they just make a bunch of ledges. So we'll have to be careful about that. But it's a small enough tip, I think, to fit in there easily. Turn to the right for me. Thank you. Sorry, you guys are all going to have to be car sick if we're not careful here. Good. He's actually following the isthmus a little bit better than the round one did. That's first time. Okay, this exercise is just about completed. I don't want to remove a whole bunch of dent in here. And why would I have a gentle wave if I'm not going to use it in this kind of case and depend on it, right? Okay, so my plan is use gentle wave, and we're going to cut a little, we'll do a little shaping in these two canals, and the carriers hopefully will move the material as far as I need it to go. Let's do a little bit of negotiation. We're going to switch around and see if we can get a better view from the 9 o'clock position. There we go. How's that? Yeah, I think so. Let's take, I'm not going to irrigate because I have lubricant in there.
Would you like to add lubricant?
Did I not get that in there? No. Not paying attention. Well, I can't do it from that. I got to do it in the right direction here. Here goes the lube. Cool. Okay, I'll take a straight 06. We're going to go in the mesolingual. Turn this way, thank you. Okay, that's definitely in the mesolingual canal. Got an impediment right there. Just click past it. Let's check it with an apex locator. It's always good to know where you are. And we're getting half a signal. Sweet, we're actually a little close. Turn this way, thank you. Sorry, Andrea, just trying to get this view between my fingers is not that easy. Okay, let's check the length again. We're still a little bit short. What was my estimate in the mesial? Was that like 21? Okay. What do I want to do? The last thing I want to do is move any pulp tissue into the way. So we may not go to the end of the root canal until after gentle wave. Let's do a little bit of smoothing here. And I know that it curves to the buccal. I don't have a bend on this, but I think the file has been bent by the canal. And it seems to be going a little deeper. Let's see if we're there yet. Nope. Let's take a file and make sure it's not buckled. Indeed it is. I love that. My point here is, and look, we've broached part of the pulp. If you never move a small file more than 90 degrees in a clockwise direction, you'll never break one off. You can rotate, you can tip your chin up a little bit. You can pigtail them 3 or 4 times, but they will not come apart unless you rotate them. So these should be using watch, wind, push, pull motion only. For gosh sakes, they're just like little. I like training dentists with true teeth because they're so much easier to ledge than these things. Yeah, I tell students that if you can avoid ledging this silly thing, then you are going to never ledge a root canal the rest of your life. Let's get a length here so I at least know where I'm at. I'm going to use the, actually, we'll use the mesobuccal. Mesolingual cuss tip. Okay. Yeah, I changed it so that's going to give us more like a 23, I think. We're not there. Yeah, we're close. So the length to this impediment is 25 millimeter file. That's a millimeter gap between there. So it's 22.5 millimeters. Let's put a little bend on it and see what happens. Endobender plier, got it. Sometimes the little tiny files are not that great for sneaking around impediments. We'll find out with this one. And the reason I need a new file, the reason 08, they're so thin that they won't hold a bend before they get to the, until they get to the impediment. So here we go. You want the very last flute bent, none of the rest of them. You don't need it. If you get the tip of the file past the impediment, the rest of the file always follows. It's magical. There we go. That's more like it. Actually, I'd rather have more, almost a 90. Great. Now I'm going to look down the length of the instrument, make sure that my bend is indicated correctly by the stop. What's our estimated length here? I said 22.5 last time for the impediment.
25.
No, I just measured to the impediment, remember?
22.5.
Right, so that's where I'm going to counter the impediment. I've got that on my file. Got this little guy bent to the side. And that goes in the orifice, flips around, and we know that curvature goes to the buccal. Turn this way for me. A little bit more, thank you, perfect. Okay, so the curve is directed there. It just clicked past something, I think. Let's check and see. I don't think this is a mesial buccal or mesolingual. I think it's in the distal shoot. Okay. Can I have a cotton plier? New 08. Okay. I think I buckled this thing. Oh, cool. This way. We're in the distal again. Let's see for a length. Nope. Actually close. I think I broached some more pulp. Okay, we are on the mesolingual now. There we go. Could have buckled, might have gone in to new pathway. A little higher might be better. Okay. Yeah. So as long as I'm just touching the dentin, not threading my way into it, I should never have a problem with ledging. So I'm unable to get around this terminus. Let's see if I can get around the distal. I usually start with a straight instrument because almost all canals don't have impediments. Here's the distal. I'm long. Awesome. I'm going to rotate this until I'm just right there. I just got length in the distal canal. Very happy. I wasn't sure that either of these would be negotiable. So far we have one of the two. So that length is 23, just like we thought.
Distance 23.
Mm-hmm.
You need reference point for this?
Reference point is the mesial buccal cuss tip. Let's put a 10 in and see if it goes. That was without bending. Nice. The distal actually may have a portal of exit that's not horrible. No. And doesn't want to go. Let's put a little bend in it, see what happens. There we go. It just dropped through. Let's see if we're not long here. Nope. Well, it's got more curve than these guys. Files want to go around a bit. There's no pulp tissue there. We broached the pulps. Let's go ahead and set up the platform and do gentle wave. Actually, before we do that, I need to get a length. Put a 10K file in here. We're going to get an absolute length where I can enlarge to where I want to keep out of there. So we're good at 23. Actually, 23 and a half. And the mesial buccal, or sorry, mesiolingual.
Oh, you got a 22 and a half to the pedal.
Mm-hmm. That one we have by the mesiolingual cuss tip. What was that, 22 and a half?
Yes.
Okay, so 22 is our length there.
22 even?
Yep.
Both same reference?
Sorry?
Same reference point, the same one?
Mm-hmm. Let's flip this around now. I'm going to draw it to the buccal, see if it'll open anything up there. Yeah, okay, that's not going to happen. Could I have a 1504?
Do you want to set
22.
22?
Mm-hmm.
22.
Okay. Okay. Okay, I wanted to get at least one rotary file to lengthen the mesial because it's really tiny. The distal is pretty good size, so I'm not worried about that. doing that before, necessarily before gentle wave. Okay, starting to get clean in there. Do we have any, let's check for undercuts. Again, the 16B helps me do that. It's like a 17 in many ways. Okay, it's all good there. We're good there. Okay, those are gone. So we qualify to do gentle wave. First, scrub the tooth, the adjacent teeth. Let's give her a little bit more Sitness Forte. I really don't want her feeling anything on this. Turn this way for me. Thank you. Suction back there. We have an awesome patient today. Her mom is a hygienist who may be watching the root canal, we're not sure. Okay, so here I am giving additional anesthesia through this super convenient place. Okay. I don't know why that's so hard to get in and out of there. Suction that. We used to shield this, then I realized I'm trying to get the stuff set up so it doesn't matter if it prematurely sets. There is no premature setting for a platform build. I found the greatest success when I have included all the adjacent spaces, surfaces I can. This is my plasma curing light. I love this thing because it's a 5-second cure. Okay. All right, the next layer is going to have a platform former in it. Great, right there. You're perfect. Right like that. Okay. Well, forgot the sponge. Smart to put a sponge in there. I mean, it's not hard to get stuff out, but and as shown by the trainer, it's still to this day the easiest way. Get a perio probe up there, and then you want to come back in and make sure you light cure most intensely the part that's right next to the tooth and the axis cavity. So, LA Diamond Burst, super handy for this. See what we got in there. Oh good, we don't have a bunch inside. It is a learned skill to make a platform. Usually takes, once you get your sea legs, it's like 2 to 5 minutes. If you have missing walls, We used to worry about that. We used to build really elegant glass ionomer or composite. Oh, that's pretty nice. Almost good. We don't want any little shards because they'll flip up during the gentle wave. What are you saying? So we have the interface there, no voids. Let me check and make sure I don't have a fin on this front part. Wish I knew which one was which. We're good. Okay, let's measure the depth. I have to figure out what the depth is to the pulp chamber floor. Oh, it's a ways. Never used a 10, but most time like today. Let's just measure the pulp chamber floor for you. See, this is a Toradon-like pulp chamber, so we would expect that. Yeah, we're at more than 12. So here's a 12 or 10. There's the ceiling cap that gives us the longest projection into the pulp chamber, the access cavity. And then we have the procedure instrument. We call it procedure instrument because it's less scary. Just like the joke in the New Yorker. I saw when I sent to my friend who, Bob Guyette, a little shout out. But Bob Guyette already knew that. Okay. Let's just take a look before, and we'll compare it to after. We don't have any junk in here, but wow. What would you do with this, knowing that there's a swath of canal between those two canals and you can't get a file into it unless you wreck the tooth? Okay, this is the most effective and most boring procedure I've ever done in endo. Yeah, that's like nothing's happening. If everything's going great, nothing's happening for, like 8 minutes. Okay, so we've got a nice seal there. I'm going to put my foot on the foot pedal. And what we want to see is the solutions clear up. I'm going to move this a bit so I can get a better view. Yeah, we got to fix this 2D camera. It needs to be put differently. Okay. Back to work. Okay, so if there's an adequate seal, then there will be no air in that little clear sealing cap. We don't want any air in there because that releases the negative pressure environment that they've worked so hard to create. My earbud just went out. You want to give me the other one? Yep. Oh.
No.
Yep, I can. Okay, I thought it was just, I thought I heard the battery noise. Oh, check it. Okay. We haven't achieved pressure we're looking for. Let's give it another go. I think we're talking too much. So this creates a Venturi effect,
LiveEndo broadcast.
which
Just wanted to let you
causes
know
the
that
negative
DV
pressure
Labs is currently having
environment.
an e-sale
In a
on
negative
our
pressure
website.
environment, we know that we don't have to worry about
Be sure
any
to
of our
act
irrigating
fast, as this
solutions
offer ends on the
moving
21st
periodically
of May.
because they
Thank you again, and enjoy the rest of the broadcast.
if you ever want to just clean the pulp chamber and have a little help finding canals, you can run this. We're having trouble. I'm having trouble staying steady enough on this. Let's try it one more time. Just distill the water. Section. I think I'm the leak. I don't think there's a leak in the rubber dam. Let's just take a look inside though. Okay. That won't matter. Just checking our fluids, make sure we have everything we need there. Yeah.
It was the bottom. Very good.
It was the bottle? Oh. Okay. Nice. It's not me. Okay, let's see if that's going to work. Not that easy to hold something firmly for 8 minutes in exactly the right spot. Can I have a cotton roll? Would you bite lightly? Oh, we have a bite block in there?
Yeah.
Okay. Never mind. Almost done with the leak test. We passed. Now hypochlorite is being used. This is a 5-minute routine. The way this works is they create a multisonic energy, can you section in the back? Multisonic energy generator, and that sonic energy goes down the root canal, and that's what jars and shakes everything loose. The thing that takes it out is the negative pressure environment. And that is created because the solutions are coming through this handpiece at 6,000 psi. They hit this little, I'll actually show you. They hit this little impingement spot. It's a little thing. Check this out. This is pretty cool. Okay, so if we look in there, we can see that it's curved. And so the fluids come through here, they hit that impingement plate, and they're shot back into the exhaust thing, which is right around the edge there, and shooting the solutions back in this direction. That's what creates a Venturi effect. That's what creates a negative pressure environment. The thing that causes the sound energy is when it's hitting this and it's being reflected, it's ringing this little piece like a tuning fork or a bell. And that sonic energy is traveling down the fluids. Sound energy travels better through water than it does through air. And so, fortunately, root canals have hard tissue in them, which reflects sound. We're going to go back to work here. And when that sound energy gets to the soft tissues at the end of the root canal, it's just dissipated. It's the most genius method of limiting, cleaning and limiting excess of sodium hypochlorite. We're almost got a minute in. I'm having trouble seeing that really well. Okay, hold this. There we go. That's the view I want. All right. And when we start up again, we typically see a little bit of bleeding because all that inflamed tissue that's being cleaned out of there, just sitting around the clump, and it comes up in a little bit. Move the scope towards me. Okay, thanks.
Is that okay?
Yeah, focus. The other one. Don't dial it, it's a motor. Usually you can see that little part inside really clearly. There we go. First time users will get a little freaked sometimes, because when you get done, you're going to always see bleeding coming out of the canals, because there's a wound at the end of the root canal. And there's been a suction on this thing. If you put a soda straw and secured it to the access cavity and just pulled a vacuum with your mouth for 8 minutes, when you got done with that, it would bleed, because all the little capillary beds would have been opened up. And that's really good for us, because we want all that stuff to come up the exhaust port, not stay in the root canal. Okay, we're almost halfway through the hypochlorite cycle. Just hit it. It moves, and then it's a motor. I don't think this, for some reason, this, yeah, this sealing cap's not very clear. Okay, 2.5 minutes. Let's just take a look in there. You can stop it anytime you want. Oh, nice. That's good news. Awesome. Okay. Go back to work. Just to see how well this works, I had a couple of really severely, hold her jaw for me.
Your jaw.
There we go. Can you, who's moving this cursor? Huh?
Chris.
I'm moving it?
No.
Oh.
Chris. Can you take,
That was a true vision cursor. It's like, hey, I'm here. The motor would be great if it had just a little bit more padding, and I think they're working on that for the next version. They're coming out, hopefully one of these days soon, with a reusable titanium procedure instrument. The handle is used just like all of our other instruments after autoclaving, and just the very tip is changed out. So we'll have less recycling, and that makes people happy too. Okay, 3 minutes and 10 seconds. Three and a half minutes. Are you doing okay, Andrea? I know I'm clamping your jaw in my fingers. Are you all right there? Mm-hmm. Okay, I've got to hold a firm seal, and it's not that easy. Okay, we're almost at 4 minutes. Thank goodness I have heads up. I can sit back in my chair. I did a live demonstration at the AAE meeting this year. I didn't have my heads up. I had to look through oculars. Didn't like it. I knew I didn't like it, but I was reminded. 4 minutes and 17 seconds. Just about done with the cleaning cycle. We have another 40 seconds. Bob Guyette has agreed to put together a list of jokes that will come up on the monitor on the menu system there. Just want to make sure we're good back behind. Okay. "20 seconds left with the hypochlorite cycle." It's going to do a 30-second rinse with distilled water after this. And that's the end of it. We're in the rinse cycle with distilled water. The final cycle is with EDTA solution. And now the EDTA has started. This is a 2-minute cycle. And then we have 15 seconds and we're done. So it's a little bit boring, but it's way better than having to work a lot harder. To get files around those canals, I may never do that. I may have to fill the carrier against the impediment and just depend on this thing to have cleaned beyond it. Without that, I would have very little chance of success without instrumenting the entire canal. You okay?
You okay?
Great.
Do you have a tape? Okay.
We have some fluids in the back. Okay. That's my fault.
Better.
Do you want to rinse out there? Did we get your ears wet?
So far.
Okay. Sorry. Oh yeah, we did.
That's great.
Okay, let's just finish this up. This is a nice tooth. We have, no concerns about missing walls, crowns that have leakage under them. One of the things you find out with this is which of the restorations leak, because they will immediately report in as no vacuum. Okay, 45 seconds left. Twenty seconds left.
You okay now? Do you need water?
Okay, we're done with this gentle wave. Sorry about that. This is Optidam. One of the cool things about it is it's got a formed cavity so that you don't have to stretch the rubber down so darn hard. Turn this way, please. What I'd like them to do is put a little suction on the end of it, back in the back here, so it's always going to evacuate anything. Maria's going to get my refrigerated hypertonic solution, saline. Yeah, we've got a leak in a rubber dam or something. The cold and the saline and the hypertonicity, really good. Another great tip from my buddy Ryan Facer. And it just stops. You go. One of the best ways to stop it is to use caffeine. If you just let it sit and go have a cappuccino, when you come back, it'll be all good. Okay, let's see what we have. I think it's gonna. We've got enough hemostasis to see what's going on inside there. Oh, nice. It's all connected up. Solution went out from the mesial buccal. Watch this. Hold this for me, please.
Here.
No, here. Okay, solution. Okay, it's up in the mesial buccal or mesolingual. It's gone. So we have a complete system here, all connected up, which is really good. Because I'm going to obturate this thing and see if we aren't going to have all the 3D stuff taken care of. So I'm going to use a 20 plastic carrier. I prefer. Did we use a 04 in there in the MB or ML? Yeah, we did.
No.
Oh, okay. No, that was an 04. I didn't put a 6 to length. I was worried about the coronal curve. And then let's just gauge the distal and see what that looks like.
This is 23 even.
Okay. Carriers begin. The first product was.
30.
I'm going to gauge the distal and see what binds at length, just to make sure I have the right carrier. Was Thermophil. Ben Johnson designed that thing, and really successful. I've learned how to use carriers, and I really love them. I think they're very effective ways to fill root canals. So we probably need to have an 06. So I'm going to do a 3006 in the distal, and I'll put a 2004 in the mesial. And I don't need to measure them. I'm just going to put them in until they bottom out. And because of that, I get to cut the stop off, which is nice because they always have to be taken off before you can put the second one in, which is a terrible bother. It's a quality problem. There we go. Okay, and those are going to go in the oven. Okay, we're only going to be able to, okay. We're coming down the home stretch.
Favorite.
Yeah. We're going to have, we're going to need a alligator impression from you when we fill this first root canal. I'm sorry, yeah, right.
Canal, right?
Mm-hmm. And we're going to use Kerr Pulp Canal Sealer. Do you have that? I
Yeah.
forgot to tell you.
Can I mix?
Yes, please. I'll need more paper points. Just leave me with those. You mix, I'll do this. Need to powder this down. It's too sticky. Close your eyes. Good. We're seeing the heme slow down, in the distal at least. So my technique is going to be, we're going to put the sealer in, blot the surplus sealer, make sure we don't have too much of it, and then we'll put the carrier in. Do not want to have too much sealer for your carrier because it will act like a squeegee and it will push all of the surplus out the end. I think we're just about there. Oh, that's nice. Look at that. We got a little bit in the middle. Maybe a separate portal of exit. That would be fun. We expect to see some kind of fireworks. Okay. Sealer.
Ready?
This is a classic pulp canal sealer. We use regular set. Turn to the right for me. Thank you. Hold right there. The sealer is acting as a lubricant. And you know what? I'm going to use this the way it is. Okay, here comes the first carrier.
You have to open as wide as you can. Okay?
I'm going to take the handle off.
Open really wide now, please.
Okay, that's good. We got it coming up out of the isthmus, I believe. Let's, paper point.
Yep.
You dry the distal. Let me get this guy heated in this other oven. You can reheat them as long as you want. Put the first one in. It's smaller. I always want to make sure I'm leaving a vent space, right? We don't want any surplus out the end. A little's expected. This is looking pretty good. We're just about ready to put the sealer in. All right, let's do that, sealer. Okay, here comes the 06 carrier. So I grab it, locking pliers. I prefer the plastic carriers. They're tougher. The gut core tend to
Open really wide.
they buckle if you hit anything else. See, I've already dinged on several things. Let's get this thing home. Okay, let's take an image. Take the bite block out for me.
Maybe turn towards the left. Is it okay?
Yeah, relax here. You're doing really good. Lift your tongue. Okay, perfect. Turn away from me. That way? Great. Oh. Okay, let's have you swallow first. Okay, I know. I would have done the same thing. Relax your tongue if you can. Great, here we go. Okay, it looks like there's 4 of everything. We're still moving.
Open one, please. Maybe turn towards the left. Still there.
Okay, let's get a little bit more distal.
Maybe turn towards the left. Don't swallow, stay still.
There we have it. Okay, I'm not happy with that. I want that to be deeper in there. So let's pull the carriers out, do it a different way.
Can I put it to face back?
Mm-hmm. Please. Interesting. So we have some of the finning coming across there. That's nice. But I think we're going to have to do a down pack to get this to move the way that we want. Hemostat? Taking carriers out is super easy. Headstrom file, curved hemostat, that's about all you need to do. Okay, so let's remove some of the sealer paper points. Did somebody turn that off? Okay.
6.
Can I have a 2006?
2004.
Sorry, 2004. One strategy I didn't try but should have was condensing around it, around the carriers. I do that.
Can you open a little wider, please? Thank you.
Let's irrigate.
Okay.
Mm-hmm. Do we still have a minute or two on that? Let's use it. Maybe. I don't want to platform it. Okay, chloroform. And in the meantime, could I have an 08K file? And you have a endo bender over there? This way. Thank you. So as I usually say in these demos, the more challenging time I have, the better it is for you guys. We're going to stir this around a little bit. Just have a couple little particles in there.
Can you open wider, please?
Yes, please. That'd be great. Paper point. So we've got chloroform in there. Paper points are going to wick up the chloropercha. You see it moving right through that paper point. It's above my cotton pliers. And this will come out clear after a little bit. Look at that. Can you put a cotton ball in there? We got more than I need to.
Here's
Great, thanks. One nice thing about pulp canal sealer is it works with chloroform. So it'll just soften up the gutta percha a little bit. This will work out great. Okay. Let's put a lubricant in there.
which one does it?
A lubricant. Do you have some? And let's see if we can get to length. So I was hoping I wouldn't have to work so hard, but now I have to go down there and get a file into all these irregularities. I don't do that with anything but lubricant in the canal. I'm going to put a 10 in the distal. You have had patency there. Make sure the stop, mark on the stop is towards the curve, as it is. Okay. Apex locator. Nice. Nothing down there? I'm just going to smooth things up here with a 10. I'm not going to get serious about taking it to length. We're at 23 and a half. What was our length?
For the
Distal?
23.
Okay. We may have a different portal of exit here. I remember that it was kind of dancing around the impediment, and then it just clicked past and went long. That was the 08. Let's try an 08. Pitch it. Let's try a smaller bend. And curves to the distal buckle. There we go. Awesome. You know what? I'm going to put a carry in this. This should have worked perfectly. Okay. So our length, that canal is 25.
This.
By the mesiobuccal cuss tip. Let's see if I can replicate that bend. Put a 10 there. We should take a radiograph, huh? Yeah, remember it was to the distal, slightly to the distal buckle. There we go. I just felt it click past. Awesome. And we look at the little indicator in the stop, it's to the distal. Okay, you know what, we're patent. I'm going to put a sealer in there and seal this thing again. Let's dry the canal. We're going to just do the distal, get it right, and then we're going to worry about the mesial. I do. When I put the distal carrier in, it didn't feel fully heated. It was already partially cooled off for some reason. I must have been dawdling or talking. Okay.
Paper?
Yes, please. Go ahead. Start without me. Did you have, okay. Let me just check and see where the 20 and the 30 fit. So the 20 goes very close. The 30. Okay, you know what? I'm going to put a 20 in and then a 30 next to it. I've got a big space there. I know we saw on the obturation film that there are lateral voids, which only means that we didn't have enough hydraulics in there. Come on. And a 2006. Do you have sealer mixed?
I do, I'll check this.
Hmm?
I do.
Okay. Is it still good?
I'm gonna check that.
Okay.
No.
Remix.
Can I give you the paper form?
I'm sorry?
Can I give you the paper form?
Yes. Okay, so we're very close to that length. I set that up at 23 and a half.
25.
Yep, exactly. Okay. Yes.
Suction.
Turn the right a little bit. Thank you, right there. Can I put some more in?
Yes, I'm sorry. Do you need another paper form?
I do. A little bit too much there. Okay. It's not a tough one. Let's see if we can get this other one alongside it now.
And open wide again, please.
Okay. Let's put a gutta percha point in the mesiolingual and cut this off with a preppy burr so I can condense it.
You want to put a gutta percha?
I do. Do I have all the gutta percha?
Yes, you do.
Oh. Using a backfill point. Don't want to have any of this plastic flash.
Rub it off.
Okay. Plugger?
Look at your plug.
Sure.
You like to take an image?
Hmm?
Would you like to take an image?
I would. I would love to take an image.
Open it.
Okay, lift your tongue. Relax your tongue. Great, here we go. Steady. All right, way better.
Oh.
I'm not even gonna have it on there. Yeah. Let's see.
Can you move your tongue towards the left side, please?
Yeah.
And open. Okay.
Ready?
Yes.
Nice. That's what we're looking for. Yes. Okay, so let's fix the distal. It's looking great. Hmm?
Sumicio.
Yeah. So not so much isthmus showing on the post-op yet. Okay, we got some cleaning up to do here. Turn to the right. Okay. Right. Okay. Only problem with the carriers, they're a mess to clean up. Air abrasion is awesome for that. We'll show you that later. Hopefully not too much later. Okay. That looks pretty good there. Could I have the red plugger?
Yeah.
And I'll take a 1506.
Ready, please?
Mm-hmm. All right. I know I keep turning your head back this way. It's the only way we can see in here. You're going to have a neck ache. Me too. Okay. Lube? So how did I bend that thing differently than before? I put a little bit more of an abrupt bend on it. Yeah, I don't think this ender bender grabs very well. There we go. That's just almost too much. Perfect. Here's a notch. Okay, we got to get that bite block back. I'm not able to get there. Right there, right there? Great. I'm sorry. Okay, our length in the mesial was 21.
The mesial was 22.
Yeah. I think it's longer than that, but we'll find out. Again, we could have slipped out a portal of exit. I gotta get my cheaters. Here we go. Okay, we got the bent file in there. See, it wants to come to the mesial maybe. It's got a little bit of an S curve. Just dropped a millimeter. That's really good. Let's check it with an apex locator. Nope. Your finger rest, so you're gonna just barely pull that little guy up. And S curves go back the other direction, so let's see if that helps. Hmm? Just dropped someplace new. Probably not patent, but closer to it. look like maybe a buckled at the end. Let's check. It is. Okay, let's try 10. Like I said, sometimes a 10 is going to maintain its rigidity enough to get around the apical impediment. You're being an awesome patient. Thank you so much. Okay. Pretty important to have the stop in the right place, because otherwise you won't know how you got to length if you have to fight your way there. Turn this way a little bit. Okay, meaning first impediment, turning to the mesial, now to the lingual. Notice I'm only watch winding, not turning, certainly not clockwise. Let's see what happened here. Okay, we're not there. And every so often, just because this worked once when nothing else would, I go ahead and peg all the stops. I tried a straight file. I couldn't get the length no matter what. Tried a straight file and it went. That's when I quit bending all my files. Sometimes the Canal will bend your file. You may buckle it. I think that's what's happened here. No joy, but we're close. I figured I've got it clean. I just want to get a fill to the end. I just need to get a patency file to length. Reload with sealer. Can't be kinked. Number 30 shaper file. Oh, 3D shaper? That's an option. That's not gonna help me get patent, unfortunately. That's about as close as I'm going to get. Let's put a 30 in there. How's the sealer look? Okay. We're not going to be shy about this one. We're going to leave a little extra sealer. Just make a new mix. And Just waiting for her to mix. Got dry canal here. So why do carriers work great with impediments? Because carriers push sealer and gutta percha ahead of them. Cone fit, cones that are fit in a nice shape will not do that. Let me have just a little bit more.
Yes.
Okay.
You can ask us as wide as you can on the return. Now, go ahead and open more, please. As wide as you can. Open. Thank you.
There we go. I'm going to have you place it. Turn this way for me.
Move your tongue towards the left side again, please. In the section. Okay. Move your tongue towards the left.
Okay, just straight on.
Okay.
Okay. That may be all we get here. Let's cut it off and condense it though. That, I think, helped us
Is your
last
water
time.
off?
Water is off, yes, thank you. So a preppy burr is a non-fluted burr. And what it does is creates frictional heat. Open, turn this way for me. We're almost done. Okay.
Good plug.
I'll take a blue plugger, yeah. Can I have the 70 of the yellow? No, the yellow plugger,
The yellow
right
plug.
there.
All yellow.
Okay, let's see what we can accomplish here. Binding. Yeah, we are. Okay, red. Got it. Let's see if it changed. You can see there's sealer down that little hoop-de-doo. Oh my gosh, I hope I got that pushed.
Okay.
Ah, I can see sealer right around that little irregularity. Let's heat it up and condense some more. And I'm going to use that red flutter. Hold this. Don't know if this will make any difference, but definitely worth a try. I'm pretty sure, I think we have sealer in that last little irregularity. Yeah, that's about it. Let's sandblast this thing. Your root canal's done. Looks great. Yeah.
With this, we can ask you to close your eyes, please. Open your eyes, please.
And this way? The way it makes your neck hurt? I know it does. That's the only reason you're changing your posture. There we go. Watch. Okay. Let's put some glass animal in there. Oh, I'm going to condense her around a little bit. Do not use your mirror when you're using air abrasion. Your mirror will be done. Okay. Glass animer, flowable glass animer. It's from Boco. It's new. Yeah.
Can I put this one?
Mm-hmm. Please. All right. Well, that was a good demo case. Nobody wants to see something that's easy and silly. Okay. Oh, yeah. That's great.
Need more you.
Perfect. You have to get a, I don't know, I'll have to figure out. You need to build up. You may need a new crown.
I have a crown.
Huh?
I have a crown.
You have another crown?
I have that one.
Oh, oh, okay.
Right?
Well, we made it. Is this a temporary crown or permanent crown?
Permanent.
Okay. You may just need a filling. Have your dentist check it out and see what they think.
For the extra.
Yeah. Okay, one of the most important things with the X-tip is you need to remember to take it out. So we're going to take the rubber dam off. And then we'll sneak back and grab that little guy. I had a patient that went to the reception area and said, I have a question for the doctor. And I came out and said, what's the question? He said, how long do we leave this in? I said, let me take a look at that. You know, maybe, gosh, I think we can take it out now. That was brilliant. Bless you, Ryan Facer. Air. Check inclusion. Close down. Tap, tap, tap. Grind right and left. Open. Just a provision material. Look how all that contoured back. Third time back. Try that again.
Okay.
Close down. Tap, tap, tap. Grind right and left. Open. Looks perfect. Only on the natural tooth, or the crown was there.
Either 40 to 40.
Yes, please. Okay, so we're going to take our patient off to get a small volume CT scan, but I think we're going to do a little applause for her right now. Thank you, you're awesome. I'm going to set you up. Yeah, that turned out really nicely. We filled the lateral canal and the distal. She's going to take a standard film or two. This case was great because you got to see the use of carriers with impediments. You got to see the use of gentle wave, and what you do when the carrier doesn't work, pull it out and use it again. Thank you. We'll be back with you later with all the post-ops and commentary. Thank you.
Thank you for tuning into our LiveEndo broadcast. Just wanted to let you know that DE Labs is currently having an AAE sale on our website. Be sure to act fast as this offer ends on the 21st of April. Thank you again and enjoy the rest of the broadcast. Thank you for tuning into our LiveEndo broadcast. Just wanted to let you know that DE Labs is currently having an AAE sale on our website at delendo.com. Be sure to act fast as this offer ends on the 21st of April. Thank you again and enjoy the rest of the broadcast.